So hey everyone, welcome to Core Vet. So today we are going to discuss about the chloramphenicol in this particular lecture. Okay, so we are beginning with the general introduction. Okay, first of all we will be discussing about the general introduction about the chloramphenicol. Okay, so if we talk about the general information regarding the chloramphenicol, so if we talk about the what is the source of this particular chloramphenicol, it is the Streptomyces venezuelae. Okay, so what it is? Streptomyces venezuelae. Okay, so this is what the source for chloramphenicol, right? It is the source for the chloramphenicol. If I'll draw the structure of the chloramphenicol, okay, so this is a benzene ring in which the nitro group is attached, and then there is a CH, then a OH here, then CH, then CH2OH, another NH, C double bond O, and CHCl2. So this is the structure of what? Chloramphenicol. Okay, so this is the structure which is responsible for the action. Now this particular moiety, which is known as the nitrobenzene moiety. Okay, so this particular moiety is responsible for the antibacterial action of chloramphenicol, right? So this nitrobenzene moiety that is there in the structure of the chloramphenicol is responsible for the antibacterial activity of the chloramphenicol. Okay, and similarly this particular moiety itself is also responsible for a adverse effect, which is the bone marrow depression, right? We will be discussing it in the adverse effect while we were discussing about the your adverse effect. We'll discuss it there. Okay, but this particular moiety is also responsible for the adverse effect that are there. Okay, and if we add certain groups to this particular structure, we will also get the chloramphenicol derivatives, right? We will discuss that too. Okay, now talking about the general properties, so it is in what? A broad spectrum drug. Okay, it is what? Bacteriostatic. Okay, it is highly lipid soluble. Okay, highly lipid soluble. Okay, this drug is highly lipid soluble, right? So these are the three major property that a drug should have, right? And it is also what? Light sensitive. This drug is quite sensitive to the lights. Okay, so it should be kept away from the lights, right? Because it may destroy the structure of this particular chemical compound, which won't be showing then the effective response to the patient, right? So that's why this particular drug should be kept away from the sunlights, right? So because it is light sensitive, right? Moving further, so see, there are several salts that are there in the market. Okay, several commercial preparations are there in the market. We talk about few. The one is the chloramphenicol palmitate, right? There is another chloramphenicol succinate, right? And one more is there, the chloramphenicol pentothionate, right? So these are few commercial preparation in which the chloramphenicol exists in the market, right? And if we talk about the palmitate salt of this particular chloramphenicol, it is insoluble in H2, means water, and springly soluble in alcohols. Okay, so it is what? Insoluble in water and springly soluble in the alcohol. If we talk about the succinate salt, so it is soluble in both water and acetone. Okay, so this was all about the general information regarding the chloramphenicol, that it is a broad spectrum drug, it is bacteriostatic, highly lipid soluble, and light sensitive, and there are three commercial preparations that generally occurs in the market. You can watch them in the market. First one is the chloramphenicol palmitate salt, second is the chloramphenicol succinate salt, and third one is the chloramphenicol pentothionate salt, right? And if we talk about the general structure of the chloramphenicol, so in the general structure, the major importance is given to the nitrobenzene moiety. Why we are giving the major importance to this particular moiety? Because it is responsible for the antibacterial activity of the chloramphenicol, right? And it also lead to the bone marrow depression. We will discuss there are two types of the bone marrow depression that is there due to the chloramphenicol. We will discuss that in the adverse effect. Okay, so this was all about the general information regarding the chloramphenicol, right? If we talk about the antimicrobial spectrum, okay, so it is a, as I had mentioned, that it is a what? It is a broad spectrum, right? It is a broad spectrum drug. Okay, so it is active towards what? Gram positive, gram negative, rickettsials, chlamydia, mycoplasma. Okay, so special efficacy is seen against the salmonella typhi. Okay, anaerobic and aerobic both are affected by the chloramphenicol. Okay, but it is inactive against what? The mycobacteria, nocardia, pseudomonas. Okay, and many proteus species, virus, fungi, entamoeba, and plasmid, right? See, we had discussed that too in the tetracycline also. That tetracycline was also ineffective for the fungi, viruses, and your certain organism more, right? So, in the similar fashion, the chloramphenicol is also ineffective against the virus and the fungi along with the several bacteria that I had mentioned over here. Okay, and but this is more active as comparison to the tetracycline against the Haemophilus influenza, Klebsiella, Bacteroides fragilis. Okay, so these particular bacteria species, if we consider for the treatment of these particular bacterial species, so it is more effective than the tetracycline. Okay, and there are certain differences also about the chloramphenicol and tetracycline that we'll discuss to that too in the mode of action also. Okay, so here's the mode of action. Okay, now first of all, the drug, obviously the drug is what? Chloramphenicol. So obviously the drug will be going to enter the bacterial cell, right? Now we all know this chloramphenicol also inhibit what? Protein synthesis, right? It is also responsible for the inhibition of the protein synthesis. Now what chloramphenicol will do? Consider this to be your mRNA, right? Right, this is your mRNA, right? This is what? Your bigger ribosomal unit, which is the 50s, and the smaller subunit, which is the 30s. And we all know that tRNA is responsible for bringing what? The amino acid, right? At the acceptor site, right? tRNA is responsible for the what? Bringing the amino acid from the cytoplasm to the ribosomal complex for the synthesis of the your proteins, right? Now we had discussed that in the tetracycline that the tetracycline is going to act at the 30S and it will just inhibit the attachment of the tRNA at the acceptor region, right? But what the chloramphenicol do? Chloramphenicol attacks the 50S subunits rather than the 30S. So what's the major mode of action? So the chloramphenicol is going to attack what? 50S subunit, right? While the tetracycline was responsible for attacking the 30S subunit to inhibit the protein synthesis, right? So that's the difference between the mode of action between the tetracycline and the chloramphenicol, right? Both are going to inhibit the protein synthesis, right? But the site of the action is different. The tetracycline is going to act at the 30S subunit while the chloramphenicol is going to act at the 50S subunit, right? Both are ultimately leading to the inhibition of the protein synthesis only, right? But the site is different, right? I hope this is clear. Now, in the similar fashion, we all know that the tRNA is going to come at the acceptor region, right? Okay, and we all know after the tRNA is going to come on the acceptor region, the amino acid chain is going to be elongated, right? We all had studied regarding this in our 12th and standard itself, that tRNA brings the amino acid, then there is a peptidal chain elongation, right? We all know sequential incoming of the tRNA, right? With different amino acid as per the codons that are there on the mRNA, right? The tRNA is going to come, attach at the acceptor region, and it will bring several different amino acid based on the codon that is there on the mRNA, right? So tRNA is responsible for bringing the amino acid, right? Now after that, there would be the elongation of the what? The peptidal chain, and then the tRNA will reach the termination site and it will be going to terminate. Okay, the tRNA will going to terminate, but leaving the peptidal chain to the next tRNA that will be coming at the site, right? Now we all know that in the protein synthesis there is what? Peptide, wait a second, peptide chain elongation is there, right? Now what's the chloramphenicol is doing? It is inhibiting this formation of the peptide chain, right? So chloramphenicol is inhibiting what? Peptidal chain elongation, right? The tetracycline was inhibiting the attachment, right? But the chloramphenicol is inhibiting what? The elongation of the peptide chain. Okay, so that's the mode of action of the chloramphenicol. You can also just look over here also. See, the chloramphenicol binds at the 50s, then it is going to interfere, right? It is going to interfere what? The peptidal transferase activity, because I had told you the chloramphenicol is going to inhibit what? The peptidal chain elongation. So how that particular peptidal chain elongation is going to be inhibited? Because the chloramphenicol is going to inhibit the what? Peptidal transferase activity. So this particular enzyme is necessary for the elongation of the peptidal chain, right? But the chloramphenicol is going to inhibit this particular enzyme, right? What it will lead to? It will lead to the inhibition of the protein synthesis. Due to what? Due to what? The interference in the transfer of the elongated peptide chain to the newly attached amino acid tRNA. Okay, I had told you that one tRNA will come with one amino acid, then it will going to terminate from this particular complex, then another will come, okay, and this particular chain which is going to be there, okay, at the exit site, it will be going to the attaching to the new amino acid that will be bring by the new tRNA at the receptor region, right? So which particular enzyme is responsible for the elongation? It was the peptidal transferase, right? But the chloramphenicol is going to inhibit that particular enzyme. Okay, due to the inhibition of that particular enzyme, the chloramphenicol is leading to what? The inhibition in the protein synthesis. Okay, but in the case where the high doses of the chloramphenicol is giving, so the mammalian mitochondrial protein synthesis could also be inhibited, and which will be leading to the bone marrow depression that we will discuss, right? Okay, this is the due to the prolonged administration. So also there in the, especially in the cats, if we talk about, there is also bone marrow suppression due to the higher dosage, right? We will be discussing that particular in the adverse effect. Okay, I hope that particular thing is clear to you, right? One more important thing is there. See, remember the sites. See, this is the mRNA, right? This is the mRNA. This is your 50S subunit, and this is your 30S subunit. Now remember the particular your what? Aminoglycoside and tetracycline were acting on the 30S subunit to inhibit the protein synthesis. Okay, but your chloramphenicol, okay, chloramphenicol, your macrolides, the macrolide, I'll discuss that in the next lecture. Okay, your chloramphenicol, macrolides, and your lincosamide. Okay, all three are going to act on which subunit? The 50S subunit, while the aminoglycoside and the tetracycline were acting on the 30S subunit for what? For a similar purpose, or protein synthesis inhibition, right? I hope this particular part is clear, because you should remember this particular part, because it is important for the objective purpose that which particular drug is acting on which subunit of the ribosome. Okay, please remember this particular part, because this particular thing you will discuss that too in the drug interaction also, because generally we do not prescribe all three classes of drugs together, okay, because they are having the same site of action. Okay, we generally prefer not to give chloramphenicol, macrolides, and the lincosamide all together. Why? Because they are having the same site of action, right? They may show, there is chances that they may show what? The antagonism. Okay, they do not show the synergistic effect. They may show the antagonistic effect, right? That's why we generally prefer that we should not prescribe all these three classes of drug, the macrolides, chloramphenicol, and the lincosamide all together, because all of them are acting on the 50S subunit of the ribosomal complex, right? That's why I'll discuss that too in the your drug interaction part. right? I hope this particular segment is clear of the mode of action. Now coming on to the mechanism of resistance, how the particular bacteria is going to resist the chloramphenicol. कि भैया मुझे तेरे से act ही नहीं होना, right? I'm not going to be affected by you, right? So how the bacteria is going to respond that particular chloramphenicol drug? Okay, there are 4 mechanisms of resistance that a particular bacteria can adopt to resist the changes that may be occurred due to the chloramphenicol. The most important, okay, the most important resistance mechanism is by the plasmid mediated. See, the bacteria, what the bacteria do, the bacteria through the plasmid that the bacteria is containing produce an enzyme. It's what? The chloramphenicol acetyl transferase, right? Now this particular enzyme, what's it is responsible for? It is responsible for the inactivation of chloramphenicol. Similarly, we had studied in the aminoglycoside, please try to recall the aminoglycoside acetyl transferase that was also responsible in the resistance mechanism, right? Please do not forget all the concept that you had studied earlier, right? Okay, because in the aminoglycoside also there was an enzyme, right? Likewise, the aminoglycoside acetyl transferase. Okay, so similar way there is what? Chloramphenicol acetyl transferase in the resistance mechanism, right? But it is what? It is the plasmid mediated. Now this particular question has been asked there in the ICAR also. Okay, you should remember this too, because this question has been there, that which enzyme is responsible for the resistance mechanism against the chloramphenicol. This question has been asked already, right? So please just have and focus on this particular part. Now if we talk about the other resistance mechanism, so the bacteria may decrease the permeability towards that particular drug and do not allow the drug to enter the particular premises of the bacteria, right? And there may be inactivation of the nitrobenzene group. I had told you that the nitrobenzene group is responsible for the antibacterial action for the chloramphenicol, right? So it may lead to the inactivation of the nitrobenzene group that is there, right? So it is also a mechanism for the resistance for the bacteria, right? And or there may be alteration in the 50s subunit itself. There may be alteration in the 50s ribosomal subunit. Okay, because the mode of action is due to the action on the 50s subunit, right? So there may be the what? Alteration in the 50s subunit to made a resistance against the chloramphenicol. So these are all the mechanism of resistance, out of which the plasmid mediated enzyme, which is synthesized by the plasmid, okay, it is quite important, please remember that. Now coming on to the pharmacokinetic property regarding the chloramphenicol. So the chloramphenicol palmitate, it could be given orally, okay, and absorbed rapidly, completely, okay, in the case of the monogastric. If we talk about the peak plasma concentration, it could be attained within the 2 hours, right? And the chloramphenicol, in the cases of the ruminants, it get inactivated into the aminochloramphenicol. Okay, so in the ruminants, we generally what happens in the cases of the ruminants, that the chloramphenicol is getting to be reduced to the what? It is going to be reduced to the aminochloramphenicol, okay, which lead to the inactivation of the chloramphenicol, and such that the chloramphenicol won't be able to show the desired effect in the particular ruminant patient, right? Chloramphenicol is the chloramphenicol derivative, right? I'll discuss that too in the later of the lecture, that there are 2 types of the chloramphenicol derivative, the thiamphenicol and the fluorphenicol, right? I'll discuss them later, okay? So if we talk about the fluorphenicol, it is rapidly absorbed orally, but the milk interference is there. Likewise, there was milk interference in the tetracycline, right? Because we do not prescribe the tetracycline along with what? The milk supplements, right? Milk compounds aren't given with the tetracycline, and antacids are also not prescribed along with the tetracycline due to the property of the chelation, right? And it could be given both orally and parenterally, with few exceptions are there, okay? And there is what? 40 to 50% plasma binding protein, FNAT, right? And that too reversibly, right? Now there is wide distribution to the tissue in the eyes, in the aqueous humor portion of the eye. There is wide distribution, and it is also secreted in the milk. Can cross the placenta and the cerebrospinal fluid, right? It can attain high concentration in the cerebrospinal fluid, up to 40 to 60%, okay, even in the absence of the meningeal inflammation. Means generally we had discussed in the penicillin that penicillin can cross the blood-brain barrier only in the condition when there is what? Meningitis, right? But in the case of the chloramphenicol, what? Chloramphenicol can cross the blood-brain barrier, and the meningeal inflammation is not responsible for that process, for that particular crossing of the chloramphenicol, right? And if we talk about how this particular drug is going to be metabolized, so this particular drug is going to be metabolized by the process of the glucuronidation, right, in the liver, right, and then excreted through the urine as an inactive compound. Okay, and only 10% is excreted as a free drug. Means we all know a drug could be excreted in an unchanged form, likewise in the aminoglycoside, or it could be firstly metabolized in the liver, then it could be excreted, right? There are two processes. So the chloramphenicol, for the 10% of the chloramphenicol will be excreted, near about 10% is going to be excreted by through the free form. Okay, it is going to be excreted through urine in the free form, and rest is going to be excreted in the metabolized form, right? In the case of the cats, due to the deficiency of the glucuronide enzyme, okay, so the excretion of the chloramphenicol is slowly, because the cat aren't efficient with the glucuronidation. Okay, so we generally prescribe the drug which are generally not going to be affecting the cat liver due to the glucuronidation process, right? Because the cat aren't able to efficiently metabolize a drug which is going to be metabolized through the process of the glucuronidation. Likewise the paracetamol. Okay, you must have studied and then said that the paracetamol aren't given to the cats. Why? Because the paracetamol is undergoing which type of your metabolism? It is going to be undergo the glucuronidation, right? And the cats are not efficient with the glucuronidation process. That's why the paracetamol is generally not given to the cats, right? And the half-life we talk about in the horses, it's about the 1 hour. So now if we talk about the adverse effect, see, it is important to note about the adverse effect first. Okay, so whenever an examiner is going to ask you the question regarding the chloramphenicol adverse effect, so the MCQ part that will be there from the chloramphenicol, so the very first query of the examiner would be the bone marrow depression. Okay, which particular class of drug lead to the what? Bone marrow depression. And second is the gray baby syndrome. Okay, so the examiner, the famous question that is going to be asked from the chloramphenicol section is the bone marrow depression and the gray baby syndrome. Okay, likewise in the tetracycline also I had told you a syndrome which is the Fanconi syndrome, right? I had discussed that particular in the tetracycline. Okay, similarly in the aminoglycoside I had told you what? In the aminoglycoside I had told you about the ototoxic effect, the nephrotoxic effect, and your neuromuscular blockade, right? I had discussed that in the adverse effect. Okay, so see, in any type of examination, okay, whether it is a descriptive examination or an MCQ based examination, the adverse effect of every class of drug is a famous question, because in the descriptive answer also the examiner will be going to ask you about the adverse effect of a particular class of drug, because adverse effects are important. Why? Because whenever you are going to prescribe a drug to a certain patient, if you are not clear with the adverse effect of a particular class of drug, and if you are having a report of a particular individual that is there with you, okay, if you are not cross checking whether the report that you are having regarding the patient and the drug that you are prescribing to that particular patient, if both of them are not matching, so how you are going to be a good clinician, right? Because you are giving a not a drug then a poison to that particular patient, right? If a animal is already a kidney prone, right, there is a kidney prone damage to the particular animal, and you are going to prescribe what? You are going to prescribe the aminoglycoside, and aminoglycoside itself are nephrotoxic. So obviously the aminoglycoside is not going to be acting as an antimicrobial agent, rather it would be a poison to that particular patient, because it will be going to aggravate the particular kidney damage situation, right? That's why you should be sound with the adverse effect of all the classes of the drug, right? So please do remember that these particular adverse effects are quite important. Okay, classification and the adverse effect plus the mode of action. these three particular sections are quite important, right? If we talk about now the bone marrow depression, right? We all know that, first of all, tell me that you must have studied about the cell injuries, right? You must have studied about the cell injuries in your pathology, right? In the general pathology, general portion, right? In the general portion, you must have studied about the cell injuries, right? So there are two types of cell injuries, right? One is the reversible, second is the irreversible, right? There are two types of cell injuries that is there in the pathology you must have studied, right? Now, if we talk about the chloramphenicol toxicity, so there are two types of bone marrow depression that chloramphenicol shows. First type, bone marrow depression, okay, and second type, bone marrow depression, right? There are two types of the bone marrow depression that is there due to the toxicity of the chloramphenicol, which is generally the 25 microgram per ml of the blood concentration, right? If there is more than 25 microgram per ml of the blood concentration of the chloramphenicol, then it may lead to the bone marrow depression. Okay, so there are two types of the bone marrow depression, the first type and the second type. So the first type of the bone marrow depression is showing a reversible stem cell injury. But the second type of the bone marrow depression is showing what? The irreversible stem cell injury. Because stem cells are quite important for the synthesis of any sort of cells that is there in your body, right? It is quite important. Stem cell is quite important for synthesis of each class of the cells, right? So what it will lead to the chloramphenicol. So how chloramphenicol is going to be affecting? I had told you in the mode of action that if there would be the higher doses or the higher concentration of the chloramphenicol in the blood circulation, it will lead to the bone marrow depression. How? Because the chloramphenicol is going to inhibit the protein synthesis, right? Protein synthesis of the stem cell, right? Which is mitochondrial based, right? So it is majorly going to affect the mitochondria. So obviously we all know the mitochondria is the powerhouse of the cell, right? If the mitochondria is going to be affected, so it will lead to the depression in the cells, right? The injury will be there in the cells, right? So the primary type of the bone marrow depression is the reversible stem cell injury, while the secondary type of the bone marrow depression is the irreversible cell injury. So let's look in the detail. So the primary type is more important in the animals, right? And the secondary types is majorly the concern of the humans, right? We talk about it is non-regenerative anemia, and it lead to what? The reversible. Okay, it is regenerative anemia. If you are going to have the first type of the bone marrow depression due to the chloramphenicol, it could be reversed, right? But the second type can't be reversed. Okay, so I had told you about the blood concentration, that the blood concentration should be more than the 25 microgram per ml of the chloramphenicol, right? Okay, it is a dose related suppression, means as you are going to increase the dosage, or as the concentration of the chloramphenicol is going to increase in the blood circulation, right, it will lead to more and more depression. It will lead to what? I had told you, the mitochondrial injury. Okay, so there would be the suppression in the mitochondrial protein synthesis in the bone marrow cell, right, and will lead to the aplastic anemia, which is reversible, right? If we talk about the second type, so the bone marrow aplasia would be there. Okay, why? I had told you in the starting itself that in the structure of the chloramphenicol, there was what? A nitrobenzene moiety. That particular nitrobenzene moiety was responsible for the antibacterial activity. Okay, that was fine. But that particular nitrobenzene moiety was also responsible for what? It was also responsible for the adverse effect. Which adverse effect? The bone marrow depression, right? Why? Because the paranitro group that is there, it undergo what? Nitro reduction and lead to formation of nitrosochloramphenicol and other toxicity, right? This will lead to the what? A permanent damage to the stem cells, means an irreversible cell injury. Okay, so the toxicant that is there going to be produced after nitro reduction, right? They are what? They are going to lead to the damage to the stem cells, which is permanent in nature. Okay, this will lead to what? The aplastic anemia, agranulocytosis, thrombocytopenia, and pancytopenia. Okay, but this particular adverse effect, okay, is not produced by the chloramphenicol derivatives, which was what? The thiamphenicol and the fluorphenicol. I'll discuss them later. Okay, it is not produced by the chloramphenicol derivatives. That's an important point, that the if you are getting an examples, right? If in the MCQ the person is going to ask which of the following drug is going to cause what? The bone marrow depression, the examiner may give you an example. First example as the chloramphenicol. First option is the chloramphenicol, second is the thiamphenicol, third is the fluorphenicol, and fourth one may be from the tetracycline or any other class of drug. Okay, so you are going to mark chloramphenicol as an option. Okay, because the thiamphenicol and the fluoramphenicol is not responsible for the causing the bone marrow depression. Please remember this point, that the chloramphenicol derivative isn't causing the bone marrow depression. That's what the quality of those particular drugs are, right? Moving to the gray baby syndrome, it is also important because this condition is generally produced in the neonatals, right? So what happens whenever we are going to give the higher dosage, near about the 100 mg of per kg of the body weight, right? If you are giving the higher dosage of the chloramphenicol to the neonates, what it lead to, it will see, we all know that liver of neonates is not developed, right? The liver of the neonates is not developed, and we all know the chloramphenicol is, to metabolize the chloramphenicol, we do know that there is necessity of glucuronidation, right? The glucuronidation is essential for the chloramphenicol excretion, right? Because the liver is not that much developed in the case of the neonates, so the glucuronidation or the metabolism of the chloramphenicol is not that much adequate. Okay, so what it will lead to, it will lead to the inhibition in the ETS. It will lead to the inhibition of the ETS, means the electron transport chain, okay, or electron transport system, right? We all know it is necessary for the production of the ATP, right? ATS is necessary for the ATP, and the major site that is there in the affection, that the region that are majorly affected, there's the liver, myocardium, skeletal muscle, and following symptoms are going to be produced like anorexia, vomiting, hypothermia, flaccidity would be there, and distended abdomen would be there in the young one, okay, or the neonates. Okay, there would be irregular respiration in that particular patient whom you are given an excess dosage, right? So the young ones shouldn't be prescribed this particular drug because it may lead to the gray baby syndrome. And there is an ashen gray cyanosis. This is an important, what is important over here in the gray baby syndrome? Ashen gray cyanosis. The examiner may not ask you about the gray baby syndrome, rather he may ask you that which particular class of drug lead to what? Ashen gray cyanosis. So the ashen gray cyanosis is caused by what? The chloramphenicol, right? So in the cats, the clinical signs of the toxicity may be shown when the usual maintenance dose of the 25 microgram per kg body weight of the chloramphenicol palmitate ester is daily administered for more than 20 days or 21 days, right? If the young one of the cats is going to be giving this particular sort of doses for more than 21 days or 21 days, this clinical signs may appear in the neonates of the cats, right? Coming on to the next particular affecting, first one is the GIT. Okay, much more affections are there. So we had discussed, the one is the bone marrow depression, second one was your gray baby syndrome, okay, third is your GIT effect, may lead to the vomiting, diarrhea, anorexia, and to the animal. These particular thing you can write on your own because you had studied the pathology. Okay, so cardiovascular effect may be there in the rapid IV injections, right? See, rapid IV injection shouldn't be given, okay? Always when you are giving an intravenous injection of any drug, always give it slowly, okay? Because there is chances of the cardiovascular collapse in that, okay? And obviously there are certain cases where the hypersensitivity reaction in the dogs and the cat has been observed due to the application of the chloramphenicol, okay, where the rashes and fever are observed, right? Moving on the drug interaction, I have told you about the first over here. If you look that the chloramphenicol, lincosamide and the macrolides all are having the 50s subunit affinity, right, or are competing for the 50s subunit, so it may lead to the antibacterial antagonism. So obviously there are certain cases where you are prescribing all these three drugs altogether, okay, because they may lead to the antagonistic effect, right, because all three of them are affecting the same ribosomal subunit, right? They will be competing with each other, so it won't be effective to give all those three together. And if we talk about the chloramphenicol, it is important for your cytochrome P450 inhibitor. So what's the importance of the cytochrome P450 in the body? That it is responsible for the metabolism of several class of drug, right? Several drugs like phenytoin is an cytochrome P450 inducer, right? Like phenytoin is a cytochrome P450 inducer, while the chloramphenicol is what? Cytochrome P450 inhibitor. What's the function of the cytochrome P450? You must have studied that in the metabolism part of in the pharmacokinetics, that the cytochrome P450 is responsible for the metabolism of the several class of drug, right? You must have studied that in the pharmacokinetics, right? So if there would be inhibition of this particular enzyme, which is the cytochrome P450, so the drugs that are there, which is going to be metabolized through this particular enzyme, right? So obviously those drugs are not going to be metabolized, right? So if the drug isn't going to be metabolized, so how this particular drug is going to be excreted, right? So there are several drugs like your primidone, pentobarbital, and there are certain local anesthetic also like phenytoin. The phenytoin excretion is also reduced, right? The phenytoin is also an inducer of the cytochrome P450, okay, remember that too. The excretion of the barbiturates, okay, all will be inhibited, right? And it may lead to the toxicity of those following drugs whose metabolism is going to be inhibited due to the action of the chloramphenicol. See what the chloramphenicol is doing. Chloramphenicol, it is inhibiting the cytochrome P450, right? And the cytochrome P450 was responsible for what? The metabolism of phenytoin, right? Barbiturates, anesthetics, right? Several drugs, right? It was responsible for the what? Metabolism of these following drugs. If there would be the inhibition in this cytochrome P450, obviously it will lead to what? It will lead to the what? Accumulation of these following drugs would be there, because these are not going to be metabolized. So what would be they doing in the body? It will be going to accumulate in the different tissue sections, right? So these drugs would be going to be accumulated in the different tissue section, right? It will lead to the toxicity of these following drugs who are not getting metabolized by the cytochrome P450, right? So ultimately it will lead to what? The toxicity, right? So that's why this chloramphenicol is having a toxicity effect along with these following drugs. So obviously when these following drugs, if you are prescribing a certain individual or a patient, then the chloramphenicol shouldn't be prescribed because it's not good for the metabolism of that particular patient, right? And also it will lead to the inhibition in the metabolism of digoxins, phenobarbital and the propofol, right? I hope the drug interaction is clear. Now talking about the clinical usage of this particular class of drugs. So in the cellular infection you can use, in the intracellular bacterial infection you can also use, in the extracellular bacterial infection you can use, in the rickettsial infections, in the eye infection also, because I had told you that the chloramphenicol is highly lipid soluble and widely distributed in the aqueous humor of the eye, right? So in the eye infection also the chloramphenicol could be given because it attain high concentration in the conjunctiva and treat the panophthalmitis and exophthalmitis, okay? The condition of panophthalmitis and the exophthalmitis could be treated by the chloramphenicol, right? It do treat the respiratory tract infection, okay, because it will attain the higher concentration in the alveolars, right? Typhoid, I have told you about that too in the spectrum also, that it is quite effective against the salmonella typhi, right? So this is the dosage regarding the dogs and the cats and the horses, right? So moving on to the derivatives. So there are two derivatives for the particular chloramphenicol. One is the thiamphenicol, right? And second is the Chlorphenicol, right? There are two particular derivatives for the Chloramphenicol, and both do not suppress bone marrow. Both do not suppress the bone marrow. There is not any bone marrow depression case due to the usage of the chloramphenicol derivatives, right? So if we talk about the thiamphenicol, why the name thiamphenicol has been there, we all know in the normal structure, in the place of this particular group, there was Na2, right? There was Na2, right? But here, in the case of the thiamphenicol, there is an methyl sulfonyl group, right? A methyl sulfonyl moiety is there at the benzene, right? And it is highly water soluble, right? Less lipid soluble, hence diffuse slowly across the lipid membrane. Okay, it is less toxic than the chloramphenicol. We had already discussed that in the bone marrow depression part. Okay, and the action is similar to the chloramphenicol. It will be going to affect the 50th subunit of the ribosomal complex to just have an effect on the bacteria, right? Coming on to the Chlorphenicol. Okay, so why the Chlorphenicol? Because there is an addition of the fluorine, right? There is an addition of the fluorine in the structure of the chloramphenicol. That's why it is known as the chloramphenicol. There is no bone marrow depression due to the chloramphenicol. See, the fluorine has been attached at the third carbon position, 1, 2, and 3. So at the third carbon position, there is the fluorine, right? It is less susceptible, okay, for the microbial inactivation. Okay, the chloramphenicol is more susceptible to the microbial inactivation as comparison to the Chlorphenicol. Okay, it do abolish the occurrence of the irreversible aplastic anemia or the second type bone marrow depression, right? It is recommended in the case of the cattle in the bovine respiratory disease, okay, which is caused by the Pasteurella multiseda or the Pasteurella hemolytica, and also by the Haemophilus somanus, right? So this was all about the chloramphenicol. Okay, chloramphenicol. This was all about the chloramphenicol. So thank you everyone. Have a nice day.